Okay, it is few past the hour, and so we will get started. Welcome to today's webinar. I am Leslie Appiah. I am the chair of the Female Oncofertility Scientific Committee of the Oncofertility Consortium, and I'm your moderator for today. Our two speakers are Professor Matteo Lambertini and Professor Gwendolyn Quinn. The title of today's webinar is The Ethics and Impacts of BRCA Gene Variants on Oncofertility Counseling. So I will introduce the speakers. They will present their presentations. We will then have questions at the end of the presentation. You may place your questions into the chat and I will speak them loudly for you, or at the end of the session, you may unmute and ask the question yourself. So Professor Matteo Lambertini is Associate Professor and Consultant in Medical Oncology at the University of Genova in Genova, Italy. He has expertise in the management of breast cancer in young women with a specific attention to the fertility and pregnancy-related issues they face after diagnosis. Professor Gwendolyn Quinn is Olivia S. Wan Professor of Obstetrics and Gynecology and Population Health at the NYU Grossman School of Medicine. She is an ethicist with a focus on perspectives and experiences around fertility preservation options counseling and uptake, and is chair of the Humanities Scientific Committee of the Oncofertility Consortium. And Professor Mahmoud Salama is also on the webinar, and he's the Executive Director of the Oncofertility Consortium. So without further ado, we will have Dr. Matteo Lambertini share his screen and present first.
Yeah, thank you very much for the kind invitation and kind introduction. It's really a great pleasure and honor for me to be part of this webinar. As mentioned in the introduction, I'm a medical oncologist. I'm very interested into the topic of oncofertility, but I'm a medical oncologist. So today I'll be mostly focusing on the topic of impact of germline BRCA pathogenic variants, but specifically focusing on the oncofertility counseling, meaning that most of my talk is gonna be related to breast cancer patients with BRCA pathogenic variants, even though a lot of the topics that I'll be discussing also apply to BRCA healthy carriers as well. So here is the outline of my presentation. I'll be discussing the main data that we have to counsel our BRCA-mutated patient with cancer on the available strategies for fertility preservation, and then some data on pregnancy after breast cancer, which is somehow still a bit a controversial topic among the oncology community, and when there are unfortunately still some misconception in terms of how to counsel our patient in these regards. So before going into the strategies for fertility preservation, just a couple of slides to highlight why the topic of oncofertility is probably even more impactful for patients with BRCA pathogenic variants. There are at least three reasons for which there are additional issues to be considered in this patient population as compared to our oncofertility counseling in women outside hereditary breast cancer syndrome. So the first important issue is that there is a risk of genetic inheritance, meaning that the risk of transmitting the mutated genes to the children. And there are several reports in the literature clearly showing that this concern may change the reproductive behavior of BRCA carriers. Second important issue is that these women have a high risk of developing not only breast cancer, but also ovarian cancer. And there is a strong indication for receiving risk-reducing surgery, risk-reducing bilateral salpingo oophorectomy at a young age, 35 to 40 years for BRCA1 carriers, 40 to 45 years to BRCA2 carriers. This means that the window for fertility is narrow in BRCA carriers. And the third important concern is that there are several reports, mostly preclinical evidence, but also clinical evidence, suggesting that the presence of a defect in the BRCA genes with subsequent deficient DNA repair mechanism may not only translate to an increased risk of developing different forms of cancer, but this can potentially have negative consequences on the ovarian reserve and ovarian function of our patient. And if these women develop a cancer at a young age, they have to receive systemic anti-cancer treatment like chemotherapy. This can further negative impact on their ovarian function and ovarian reserve. So with these three additional issues in mind, let's move to the strategies for fertility preservation. And before going into the data that we have for counseling BRCA carriers on the three main strategies that we have, I'm just going to focus with a few slides on the so-called first step of the oncofertility counseling, meaning how to discuss the risk of developing premature ovarian insufficiency, particularly in BRCA carriers. And on this regards, the first concern is that there are data in breast cancer patients that at the time of diagnosis, so even before starting any type of systemic anti-cancer therapy, BRCA carriers apparently have a reduced ovarian reserve as compared to breast cancer patients without BRCA pathogenic variants. And the reduced ovarian reserve in terms of lower anti-Mullerian hormone levels before starting treatment. So the concern that we have to discuss the risk of chemotherapy-induced premature ovarian insufficiency in this patient is a potential increased risk of developing this side effect as compared to patients without BRCA pathogenic variants. However, the data we have, limited so far, are not going into that direction, so apparently there is no increased risk of gonotoxicity in BRCA-mutated patients. One study addressed the risk of premature ovarian insufficiency using amenorrhea as a marker of POI. The other study assessing AMH before and during and after anti-cancer therapy. However, there's a more recent study from the group of Octai showing that apparently BRCA carriers have a major reduction in AMH levels following treatment, which is even more profound as compared to what we see in breast cancer patients without BRCA mutation. So I think that the question mark on the potential increased risk of developing this side effect in BRCA-mutated patients still remain. One main concern that we have right now in our clinical practice, particularly in the breast cancer field, is that BRCA-mutated breast cancer patients nowadays are receiving a more toxic chemotherapy regimen because we tend to use carboplatin on the top of taxane, anthracycline, cyclophosphamide-based chemotherapy for most of these patients. And then in high-risk patients following standard chemotherapy, which include anthracycline, cyclophosphamide, taxane, and carboplatin for many of these patients, we use also 1 year of a PARP inhibitor, a targeted agent, specifically in the BRCA patient population. And we have data in mouse models, in BRCA-mutated mouse models, that both carboplatin as well as the PARP inhibitor olaparib may have a detrimental impact on the ovarian reserve of the mouse ovaries. And so we really need to address as soon as possible if these treatments are actually causing an additional damage to the ovarian reserve of our BRCA-mutated patient. And on the top of the potential influence of BRCA defects per se, also the additional treatment that these patients are receiving nowadays is something of concern, where we need multi-center studies to really address this important topic. So according to our guidelines as medical oncologists, we really need to discuss and to perform the oncofertility counseling with all women diagnosed with cancer at a reproductive age, as soon as possible after diagnosis, irrespective of type and stage of disease, and considering all patients receiving systemic treatment at potential risk of gonotoxicity. After this counseling, after discussing this risk of developing premature ovarian insufficiency, we have to refer this patient to fertility specialists, those patients interested in fertility preservation, to fertility specialists for receiving cryopreservation options, which are the main fertility preservation options. We have also the opportunity to offer GnRH agonists during chemotherapy. However, this strategy is not a fertility preservation strategy per se, so it does not substitute cryopreservation option, but it's an option that can be considered after cryopreservation procedures or in those patients that are not really interested into fertility preservation, but are concerned on developing menopause at an early age. And so in this case, we can use this option as a way to protect ovarian function after chemotherapy. Now, in the next few slides, I'm going to address the data we have specifically in the BRCA-mutated cohort for these three different strategies. I will start with the first and most important and first step procedure that we have in patient with cancer, which is oocyte embryo cryopreservation. The main concern we have in BRCA-mutated patient is the potential effect of having pathogenic variants in BRCA genes in terms of response to control ovarian stimulation. There are several studies that have looked into the performance of this stimulation in BRCA-mutated as compared to BRCA wild-type patient, mostly with breast cancer. And data are controversial so far. Some of these studies have shown that BRCA-mutated patients may have a reduced response to control ovarian stimulation, but several other studies have not shown any difference between breast cancer patients with or without BRCA pathogenic variants. So I think that the question mark still remains for a potential lower response to control ovarian stimulation in this patient. My main concern is that these studies are mostly single-center, small studies, and again, here we need probably more cooperative effort, multi-center studies to better address this important concern. In terms of safety consideration, particularly in the breast cancer field, for many years as medical oncologists, we have been concerned that giving hormones to patients that have just been diagnosed with breast cancer may have detrimental consequences on patient prognosis. However, we have now several studies, including this prospective study from the group of Appiah, showing that there is no difference in survival outcomes between those patients receiving fertility preservation before starting chemotherapy or no fertility preservation strategy. And in this study, there is also a subgroup analysis focusing on the BRCA-mutated breast cancer patient population, and the same conclusion as in the overall study. There is no apparent detrimental effect of receiving fertility preservation strategy before initiating chemotherapy, also in the BRCA-mutated cohort. So regarding this strategy, this is the first procedure to be discussed with all women with cancer, including among BRCA carriers. This strategy will allow access to pre-implantation genetic diagnosis, as I briefly discussed at the end and will be better addressed in the next presentation. However, the question mark on the potential need of personalized stimulation protocols in this patient still remain, because we have some concern that the defect in the BRCA genes may negatively impact the efficacy of this procedure. Moving now to cryopreservation of ovarian tissue. In these regards, we have several concerns for BRCA carriers. Actually, not only BRCA carriers, but all women with hereditary cancer syndrome associated with pathogenic variants in genes that predispose the development of ovarian cancer, BRCA1, BRCA2, but also other genes that have an increased risk of ovarian cancer. In these cases, cryopreserving a tissue and then transplanting back a tissue that is associated with a high risk of cancer is not the optimal strategy. However, this can be potentially considered in very young patients, so patients several years before the recommended age of risk-reducing surgery, with some special considerations. We have data that this could be potentially considered in selected cases, and this is a series from the group of Brussels of Isabel de Mister, where we have shown that around 20 BRCA-mutated breast cancer patients have received this procedure, and among them, 2 patients have been transplanted following treatment completion, despite knowing to be BRCA-mutated. And one of them succeeded to have a subsequent pregnancy. The main point is that we should consider this procedure as a second-step procedure in this setting and to be discussed only with those patients that have no access to oocyte embryo cryopreservation. And it's very important that the tissue is transplanted back to the ovaries, not in other sites of the pelvis, so that we are sure to remove all ovarian tissue at the time of risk-reducing salpingo oophorectomy. In terms of quality of this tissue, there are some reports showing that if we compare this tissue in terms of quantity and quality of the ovarian reserve between BRCA-mutated and BRCA wild-type patients, those with BRCA pathogenic variants may have some signals of a diminished ovarian reserve. So again, into the same direction of a potential negative effect of pathogenic variants in BRCA in terms of success of the procedure. Again, very limited sample size, very limited evidence, so we cannot perform a strong counseling on these regards, but some concern that need more and actually additional research efforts to better address this point. So cryopreservation of ovarian tissue is feasible, but it's not the optimal strategy. Very often we don't have the BRCA results at the time of the oncofertility counseling, which is right after diagnosis of cancer. And to me, I think it's very important at least to have the BRCA testing results before considering any transplantation procedure. Because if the patient turns to be BRCA mutated, then the tissue, and if she's still willing to receive back the tissue should be transplanted in the ovaries. And then maybe in the future, we will have other options for those patients that are already in age for which it's preferable to receive a risk-reducing surgery and to transplant back the tissue could not be considered safe. Finally, for GnRH agonists during chemotherapy, which again is a strategy to preserve ovarian function more than to preserve fertility, we don't have a lot of data in BRCA-mutated patients. We have a small subgroup analysis from the PROMISE GYM6 trial, which is the Italian study, randomizing premenopausal breast cancer patients to receive chemotherapy alone or chemotherapy plus concurrent GnRH agonist. In this trial, it's a quite old trial, so at the time the BRCA testing was not standard of care in all young patients. So only a few of these patients were tested for BRCA, and 10 of them were BRCA mutated. Of course, this is just a descriptive analysis, not really strong evidence, but these data are going into the same direction of what we have seen in the main trial population. So this strategy can be considered for very young women, so several years before the recommended age of risk-reducing surgery. For those patients that are very close to receive for receiving bilateral salpingo oophorectomy, I think that same consideration as for ovarian tissue cryopreservation can be made. So preserving a tissue that should be removed a few months after treatment completion is not the optimal approach. Finally, some information on how to counsel patients, particularly those with breast cancer that want to have a pregnancy following treatment completion. This is relevant because cancer survivors in general have lower chances to have a future pregnancy as compared to women from the general population, and among them, breast cancer patients are those with the lowest chances. One reason is what we have just discussed, so the risk of premature ovarian insufficiency, the lack of access to fertility preservation strategies. However, a very important reason is that still many oncologists, many of us, believe that a pregnancy in breast cancer survivors can increase the risk of recurrence, being breast cancer a hormonally driven form of tumor. And if we ask this question on the safety of pregnancy after breast cancer to breast cancer oncologists, related particularly to BRCA-mutated patients, we see that almost half of responding physicians to this survey were not sure that pregnancy is safe following treatment completion. However, these are misconceptions because we have several studies reporting on the safety of having a pregnancy following treatment completion, including among patients with hormone receptor-positive breast cancer, so the most hormonally driven form of tumor. Of course, following proper treatment and follow-up for breast cancer. We have data also to counsel BRCA carriers. This is a study that was focused specifically on breast cancer patients diagnosed at a young age with known BRCA pathogenic variants. More than 1,200 patients were included, almost 200 at a pregnancy following treatment completion for breast cancer. And again, same conclusion, no detrimental effect of pregnancy following proper treatment and follow-up. And actually a tendency for better outcomes in those patients with a subsequent pregnancy. What is very interesting is that apparently BRCA carriers have much higher chances to have a future pregnancy as compared to breast cancer patients without BRCA pathogenic variants. In the breast cancer population, we expect that between 5 to 10% of young women will have a pregnancy following treatment completion. In BRCA carriers, we have seen that this is more than double and is probably related to the very young age in which this patient developed a breast cancer. Hopefully, by the end of 2023, we will be able to report an update from this study where there are additional centers that have joined this effort, and we have almost 5,000 patients included, with more than 600 that had a pregnancy following breast cancer. So I hope that these results will provide even stronger evidence to counsel our breast cancer patients with BRCA pathogenic variants on the safety of pregnancy after breast cancer. From this study, we have also some safety data on the use of ART, assisted reproductive technology procedure, following treatment completion. Small numbers, but again, no signals that this procedure can have a detrimental effect on patient prognosis. Finally, and briefly, because I know that there will be a next webinar focused on this important trial, just a few words on the positive study, which is a pragmatic trial that included more than 500 breast cancer patients with hormone receptor positive breast cancer that had a strong pregnancy desire and that did not want to wait the standard treatment, which is at least 5 years of adjuvant endocrine therapy. So the trial allowed to temporarily stop endocrine therapy for up to 2 years to try to have a pregnancy before going back to endocrine therapy and complete the 5-10 years of treatment. In interpreting the results of this trial, we have to keep in mind that the follow-up of the first presentation that was done a few months ago in San Antonio is still a bit short, 41 months, and that most of the patients had a stage 1 or stage 2 disease, so a kind of lower risk of this recurrence. Here the safety data, apparently there is no increased risk of recurrence as compared to what we expect in such young patient population in terms of recurrence rate. And in this study, there is a small subgroup analysis for BRCA-mutated patients. Around the 40 patients had a BRCA pathogenic variants. And also in this small subgroup, the same conclusion, there is no apparent increased risk of recurrence. Finally, the safety on the baby side, because prior exposure to chemotherapy, particularly may induce some concern among us that this exposure can increase the risk of pregnancy complication. However, what we see is that there is no increased risk of complication, major malformations, or other complications as compared to healthy women from the general population. But there is a slightly increased risk of some pregnancy complications like cesarean section, low birth weight, preterm birth, and small for gestational age, meaning that we need to follow these pregnancies more closely as compared to what we do in healthy women from the general population. We have data also in BRCA carriers in these regards. From, again, our study, there is apparently not higher risk of complication as compared to what we expect in healthy women from the general population. 10% abortion rate, less than 3% congenital malformation rate. In terms of practical consideration, this is a very important one. It's going to be addressed much better in the next presentation. But we have to keep in mind that the prenatal diagnosis or PGT should be discussed and should be offered to our BRCA carriers. So my conclusion is that all patients at reproductive age should receive a complete oncofertility counseling following a diagnosis of cancer. And for BRCA carriers, the presence of a defect in the BRCA genes may add additional burden in the counseling. In terms of strategies for fertility preservation, embryo oocyte cryopreservation is the standard option. We need still to explore if these patients have a lower response to the stimulation, but these remain the first approach because it also allows the access to PGT. Cryopreservation of ovarian tissue, generic agonist during chemotherapy, not the optimal strategy, but can be offered to very young patients diagnosed several years before the recommended age of risk-reducing surgery. And then, very importantly, following proper treatment and follow-up for breast cancer, having a pregnancy should be considered safe, including among BRCA carriers and including among patients with hormone receptor-positive breast cancer. However, we need a closer monitoring of these pregnancies for a potential higher risk of some pregnancy complication. My final and most important slides of the presentation is the need to implement the so-called Oncofertility unit, so to implement a strong collaboration between us as medical oncologists and fertility specialists to have a proper care, oncofertility care of our patient. However, I can confirm from my practice that this is not only important for offering a timely manner fertility preservation option and diagnosis, and also following those patients that want to have a pregnancy, but this strong network is also very relevant to address other gynecological related issues that our young patient with cancer may have. Among them, for example, for breast cancer patient receiving ovarian suppression as part of adjuvant endocrine therapy, we may have a lot of menopause-related symptoms, sexual dysfunction, contraception issues that are much better addressed by fertility specialists, by gynecologists, as compared to what we can do as medical oncologists. And with that, I really wish to thank you again for the opportunity to be part of this webinar.
Thank you for that presentation. That's a good segue into now kind of talking about the patient perspective of this and some of the ethical issues that are inherent in oncofertility counseling. There's a lot of ethical issues that are part of all of assisted reproductive technology. It's not new. And one of the reasons, and it reminds me of the Einstein quote that it says it's becoming appallingly obvious that our technology has exceeded our humanity. Now that's a little bit extreme, but it is accurate that much of the technology in assisted reproductive technology and in cancer advances and treatments comes out before we have a time to assess what society thinks about it and what affected populations think about it. So I'm going to go through a case and ask you to think about it in terms of the principalist approach. We'll review several steps of these cases, which are actually comprised of real events and real responses from a composite group of people in the over 10 studies that we've done in the past 10 years with populations of people who are both previvors, which if you didn't know that term from Marlia Cruzel's talk, is actually credited to Sue Friedman of Force. And it's kind of a different definition of an unaffected carrier. So these are people who are known to have a hereditary cancer mutation, but are not experienced it, don't have a cancer diagnosis. And this, talking about this is important both in the context of previvors as well as people with an actual cancer diagnosis. So we're going to look at the ethical issues from the patient perspective, from the clinic perspective, and as often happens with ethics, there are no right or wrong answers. We ask a lot of questions, and I very much want to hear what you all think about these things or how you conceptualize them. So when we are doing an ethical analysis, we look at these four components that are part of the principalist approach: autonomy, respecting the patient's right to choose; beneficence, the duty to do good; the opposite of that, the duty to first do no harm or to minimize harm and to maximize benefits; and then justice, to treat all people equally and equitably, which also includes costs and access. So we're going to be talking about patients' right to choose in accordance with the clinic's right to set guidelines, and how issues of culture, thinking about the disposition of embryos, informed consent, and future forward thinking may play into this scenario. So this is the case. I'll read it in case you can't see very briefly. Ivana and her partner Simon are presenting to a reproductive endocrinology and infertility center for infertility. During the routine intake, Simon discloses that he has BRCA1 in his family and has Ashkenazi heritage. Upon hearing this, Dr. Clark suggests Simon receive genetic counseling and testing. He agrees to do this and identifies that he is BRCA1 positive. Dr. Clark says, you have an obligation to use PGT to ensure no future offspring have the possibility of cancer. So I want you to think about this also in terms of these 4 approaches again. And think about, should we ever, in the United States, and I'm going to limit this to the United States, and I know that regulations may be different outside the United States, but should we ever require someone to have genetic testing or to know their genetic results? Because people have the right, people have the autonomy to not know as much as they have the right to know. And should we require this of certain populations? Is it potentially discriminatory to say, if you have FAP or BRCA or Lambertini, you are required to do something that another patient is not required to do based on your genetic makeup? So some of the issues to consider are what you might think of as dueling issues or dueling rights. So in the United States, we have guidelines that are set by the American Society of Reproductive Medicine, the American Society of Clinical Oncology, but those guidelines are in fact just guidelines. They're not laws or regulations. And clinics do have the right to set policies and guidelines within their own practice setting that make sense for them. We do know of clinics in the United States that have certain policies that say, if we test for something, we won't implant, or if others that say we will test and we'll give you the results and it's your right to choose what you want to do next. So clinics have that authority, I should say, rather than right, authority to set those guidelines and create policies that make sense for their practice. But patients also have rights to know and not know their genetic status. And clinics also have the right to conscientious objection, which is kind of factored into the policy issues. So if among the practitioners in the clinic, they agree that they feel a certain way about something, they could say, we won't provide care to hereditary cancer people, or we won't provide care to the LGBT community. They can make those objections to do that, although they may not always be phrased as conscientious objections. From an ethical perspective, if you are not agreeing to treat someone for some reason, then which you have a right to do, the next step is to refer them to a place, or at least give the patient access where they may be able to get the care that they are looking for. But we're going to talk more about this when we talk about why wouldn't somebody with a known mutation, say, for example, BRA or some hereditary cancer mutation, why would they not want to do PGT? Well, and you know, it's relatively recent in the past 2 years that we use the term PGT, pre-implantation genetic testing, versus PGD, pre-implantation genetic diagnosis. So you'll hear both of those terms being used, and if you look at the literature, you'll see both of those terms. But some cultures, religions also consider the use of PGT to be a form of genocide. We have done a lot of research with the Jewish population, and I'll share some of those quotes later, but some feel that their heritage, whether they consider it a culture or a religion or both, is being attacked because there are known to be a series of Jewish genetic issues, and the fact that we might be creating mechanisms to test for them and exclude those embryos that have these positive traits makes people very uncomfortable and feel targeted. But clinics are obligated to inform patients up front as to what their policies are. But I would also say the flip side of that is it can be very challenging for patients regardless of their age, when we say this a lot for adolescents and young adults, but regardless of their age, to really think about the future. I liken this to telling a young couple who is in love and just got engaged that they need to have a prenup. And so you're asking them to think about a worst case scenario that doesn't fit with at all how they're feeling right now. So you may be asking a couple to think about it in the context of the embryos in general, like if your relationship ends, who owns the embryos, who can use them? Or you may be asking a couple to consider if that, you know, your clinic policy is that you will not transfer affected embryos. And so in the follow-up to this case, they agreed to use PGT in their IVF journey, although it was very financially challenging for them. The clinic had advised them ahead of time that it was their policy that they don't implant affected embryos. And at first they were thrilled to learn that they had 8 viable embryos, and then they were devastated to learn that all of the embryos were BRCA. So what are their options? Before they get to their options, let's expand on some of the reasons why people might not want to use PGT. Some of it, as I mentioned, is related to culture and religion. Some of it is related to health literacy based on family experience. So yes, for example, you are a BRCA unaffected carrier, but your mother was also, she had breast cancer, she had a mastectomy, she's fine. You may think in your experience, that's not a big deal, or that's not something equivalent to Huntington's disease where it's inevitable and and fatal. There are also people who think very optimistically that by the time their daughter or their son grows up, that new treatments or new strategies will be available. And so it doesn't matter if there's BRCA or any other type of hereditary cancer in their future offspring. Also, you might not be surprised that not in this case of this couple, because they were seeing an REI because they experienced infertility, but many unaffected carriers or previvors are not experiencing infertility, and they really want to get pregnant what they refer to as the old-fashioned way, and don't want to have to get involved in an expensive and time-consuming, process of getting pregnant. And some don't understand the science. We still have people, when we're talking about this, who think that PGD is equivalent to abortion. And many kind of refer to the past, like they'll say, thank goodness this technology didn't exist when my mother was pregnant with me, or I wouldn't be here. Some consider it genocide. Some consider this fate. If it's the fate, if this runs in our family and this is what is in our family, that is the fate of our family and we'll accept it. And some think, well, if I have a BRCA positive girl child, we can at least know this about her and we could do early monitoring. And some think that there'd be no problem in selecting a male embryo with BRCA. And again, this goes back to not understanding the science, because we know that men with BRCA also have breast cancer risk, but also have increased risk for other types of cancer. So in the case of this couple, they have 2 options. Their option that they immediately thought of was to transfer these embryos to another clinic and select males, or to repeat this process, which they felt was going to be challenging for them, both financially, emotionally, and physically. So while they acknowledge that they did hear from the clinic that this was their policy, here's some of the comments that you've heard from people in this situation. Never in our wildest nightmares did we think it was a possibility every embryo could be affected. I can't go through that process again, even if we could afford it, which we can't. This is so unfair. We were given this information on the phone and this was devastating. The clinic doesn't realize how devastating this is for us, and then concerned about these tests even being accurate. And then you wonder, why would people be concerned about tests being accurate? And that's because every once in a while in the news, but not very often, there's a headline like this where a fertility clinic made a mistake. And even though PGT for hereditary cancers, particularly BRCA, is, I believe, 98 to 99% accurate, mistakes still can be made, especially with less common cancers that are not being tested across a panel for which we have already a lot of data. The other thing that couples have said in this situation is, particularly if they're unaffected carriers, I wish I had never told the clinic about this status, because then we wouldn't be in this situation. We wouldn't have done PGT. And so you also can imagine that, like many instances where a community that often communicates, particularly during through social media, may share with each other information like, don't tell the clinic that this is in your family, because then they'll make you do these steps and you don't want to have to do these steps. So it creates potential for withholding information, or for people to do medical tourism. So if they live in a state where every REI clinic has this requirement, they may travel to another state, or they may travel to another country if they can afford it, where these restrictions won't be put on them. So again, thinking about this from both perspectives of the physician and the clinic doing this, as well as the patient and the couple, whose autonomy trumps? Is it, we talk about this in terms of patients' rights, patients' ability to make the best decision for themselves. But this often comes with us being able to ensure that we have given the patient all the information they need to make the decision that was right for them at that time. And I think that despite the fact that many clinics have genetic counselors, and many people who have a known mutation for cancer in their family may have already been through genetic counseling, I would say that the psychosocial aspect of it can be difficult for people to understand until they're actually in that situation. So again, even though the clinic may have told them that there's possibility that every embryo might be positive, I think people just can't really wrap their head around that. One way that has been shown to be effective for people to do that is through peer counseling, hearing from another person who's been through this experience, using more lay terms than medical terms, and talking about all these options and the emotions that they felt and how they handled the situation. And the other thing is, and this is probably true of a lot of reproductive technology, particularly when it comes to oncofertility, we still have many states where this is not required. It is expensive to bank embryos and to do PGT testing, which also may not be covered by insurance. So people could be paying out of pocket, you know, anywhere from $25,000 to $50,000 for one cycle of this. So I'm going to skip going over this case, because I want to just talk about the conclusion of this and then make sure that we have some time for questions. So ultimately, what did the couple decide? Well, when they expressed to their clinic that they, how devastated they were and how financially they could not afford to do this again, the clinic agreed to give them a significantly reduced rate for a second round of IVF and PGT testing, in which they were successful in getting an embryo that was not. So, you know, positive things do happen in these experiences, but I think it's hard for us in the science world to think about the way that patients think about these things. And I want to stop here so that we have time for questions.
Thank you, Gwen, and thank you, Matteo. So we will open the floor for questions. Let me move this. I do have a question for you, Matteo. So when you recommend transplanting ovarian tissue in patients with breast cancer or who are BRCA positive to the ovary, is the consideration that it's better to kind of decorticate the remaining ovary and transplant that tissue to the ovary so that you perform the risk-reducing BSO in the future, the ovary, that tissue is adhered to the ovary, or are you just really recommending transplanting to the pelvis where we can identify? And I know in general, you're not recommending transplantation at all for this population, but if transplantation is going to occur, that is a consideration.
Yeah, thanks for the question. So here I will recommend, I'm not the person doing the transplantation procedure, but I will definitely recommend to transplant back to the ovaries, not other sides of the pelvis, so that we are 100% sure to remove all the ovarian tissue at the time of risk-reducing surgery, because this is a tissue that has a high risk of ovarian cancer.
Okay, excellent. And then I have a second question. In the slide where you show the data on poor pregnancy outcomes, low birth, small gestational age in breast cancer survivors who conceived, this kind of, I think, speaks to the concern that has been introduced in literature in the last few years that perhaps chemotherapy itself has effects on youth, and that might be the cause of some of these adverse pregnancy outcomes, because it doesn't seem to be injury to the oocyte. So is that kind of the thought, that chemotherapy may have an effect on the endometrium and the uterus more than we thought in the past?
Yeah, this is a possibility. Something that I have not shown because of time is that this kind of higher risk of some complication appears to be the case, particularly for those patients with a pregnancy within 1 year following chemotherapy completion. So when the time in between chemotherapy and to pregnancy is shorter. And for those patients with a pregnancy beyond 1 year, apparently there is no difference as compared to healthy women from a general population. So this could be potentially a reason. But on the other side, we have to keep in mind that we have also safety data to give chemotherapy during pregnancy. During the second and third trimester, this is safe, it's possible. But also in this case, there is a slightly higher risk of the same complication. Mm-hmm. So we need to monitor more closely these pregnancies.
Understood. Right. And if these pregnancies are occurring within 12 months of completion of chemotherapy, it may be an oocyte quality issue versus endometrial, but we don't really know. Okay.
Yeah, but in any case, this 1 year interval, this is something that I will wait anyhow, also in terms of risk of recurrence for the disease and also for other more oncological based reasons. So the recommendation is to wait at least 1 year following treatment completion.
Agreed. Excellent. Okay. Are there any other questions for our speakers, for either Professor Lambertini or Professor Quinn? Okay, I do have another question then. So, Matteo, how are we going to convince medical oncologists that it is safe for patients with breast cancer to conceive? The literature is clear, yet we can't seem to move the needle there.
Yeah, this is a good question. We are doing a lot of efforts to try to convince medical oncologists that after proper treatment and follow-up, this is indeed safe. I think that the positive trial, even though this study has addressed a specific issue, which is stopping the treatment, is probably helping on these regards. This is the first prospective effort to address the safety of pregnancy after breast cancer. And so far, with this limited follow-up, but so far the data are positive in the sense that there is apparently no increased risk of recurrence. There are also other studies ongoing. The one I've shown in BRCA patient, we are going to report end of the year in a very big, with a big sample size. So even with more power and more hopefully definitive answer on these regards.
Thank you. Thank you. And then Gwen, when you were describing the kind of the thought that this could be perceived as genocide, I've often, when I'm counseling patients and I discuss pre-implantation genetic testing, I do interject, and this may not be ethical, so I would love your input. I do interject that there are many individuals, including the patient, who have had these genetic conditions and have lived great lives until the diagnosis, right? When they then have to intervene and undergo treatments. And so I feel compelled when I'm counseling patients to just remind them that, and to your point, there are many genetic diagnoses that we don't know of, and patients are doing well. So I just want to know if you could comment a little bit more on that.
Yeah, I think there's no one right answer. I mean, there's equal numbers of young women who say how empowering it was to use PGT and to know that their children will not be carrying forward what has decimated, their family in the past. But then there's also the thought that we are creating a society that with limited diversity, that, it's the slippery slope argument that people always talk about. Well, the next thing, we're only going to have, children born with high IQs and athletic abilities and all these other traits that we truly cannot currently test for. Mm-hmm. There's something to be said about thinking about it from an ableist point of view, that our society is richer because we have people who are differently abled and who are deaf or who are blind. And some parents even want to use PGT to select for dwarfism, for example, if they are also themselves dwarfs or deaf and feel they love their community and want to bring a child into that community. So I think there's no right answer, but I think it's important to consider, particularly the Jewish community that has this very negative history of how it can be perceived within some Jewish communities, not all.
Agreed. Okay. Well, very thorough presentation. I think in both your presentations, you answered many questions that individuals have. As we stated, this webinar presentation will be placed onto the website. And so individuals can take a look at that in the future. I'm sorry, I'm looking for something here. I do want to announce that the next webinar will be on Wednesday, May 17th at 2 p.m. Mountain Standard Time. And Dr. Ann Partridge will review and tell the result of the positive study. The title of that webinar is Breast Cancer and Fertility, What We Learned from the Positive Study. So we will see everyone in a month. And again, Professors Lambertini and Quinn, thank you so much for your time today. Thanks for all.
Ciao.
Bye.